So I know hunger is one of the best ways to remain awake, right? And I have a very good team here. And rarely you will see gynecologists and hematologists sitting together and talking to each other. But I think that is more required. So without any further ado and to facilitate your early lunch, I'll start off. So consultative hematology, let me share my experience during my residency days of a referral from the Department of Gynecology and Obstetrics. The referral read as, and this was in the year 2006, right? Not very far, 16 years back. The referral read that we have a primea gravida who has just delivered, had significant PPH, and her hemoglobin has dropped to 4.8 gram per DL. Please come and tell us how many units of blood need to be transfused. Okay? So this was a referral for the SR. I went to my boss, Professor Rajat Kumar, and told, sir, ये AIMS में ऐसा refer आया है. He said, it only means that people don't know what hematologists do. So for those of you who don't know what a hematologist does, let me tell you that we are the best pathologists amongst clinicians and the best clinicians amongst pathologists. So that is what we do, right? Yeah, so let me proceed. Pregnancy is a different ball game. And fortunately, I have my obstetric friends here. I would like to understand from them, before going into specific hematology aspects, that what important things you see commonly in your practice, which happens the moment a lady becomes pregnant. Obviously, from the blood point of view, anyone, I think Dr. Neha is there, and then Dr. Chandrakant, Dr. Nalini. Dr. Chandrakant may start. Why it's different?
There are many things,
right?
Many changes that take place. Important ones are there is hemodilution,
right?
The blood volume increases, so cardiac output also increases. There can be tachycardia. Hematology point of view, there is, because of dilution, there can be so many things.
Yeah.
And many things, as Bhavesh sir just now told, it is gestational thrombocytopenia, or some changes that occur in the blood film, natural to pregnancy.
Right. So, and other part is now you're treating two patients. One may not be a patient, might be a patient. The other also might be a patient, might not be a patient. Because pregnancy is a physiological phenomena, right? So where are you sleeping? Abhay showed you those beautiful slides. This is just a recap of what he was saying. This is the first lady, a 22-year-old woman found to have a platelet count of 82,000 on routine screening at 16 weeks of gestation. This is a second pregnancy. Her first child was delivered at term without complications. However, she had been informed that her platelet count was 62,000 at that point of time. Patient denies any history of bleeding or bruising last time, this time. History and examination are otherwise unremarkable. My first question to Dr. Neha is, how common is it? Do you see in your practice?
It looks like a gestational thrombocytopenia, though it is not a very common condition. Especially, I think around 1 to 2% of the patients will come out with this type of a platelet count. And in this case, as Dr. Abhay sir has already explained, we should get a good platelet count from a good laboratory. That is the first priority. Then we will wait patiently and follow her platelet trend, how she is performing.
So because we have a history. Do CBCs during pregnancy? Do you routinely do it?
Yes, we should do the CBC. The thing should be at the time of a booking when patient comes to you. You yes. can have her basic CBC. You can do her HB electrophoresis, and you can do a routine urine routine and blood sugar. You should repeat at least every 3 months if the patient is uncomplicated and there is no previous history, or you are not finding any abnormal clinical findings. If the patient develop over the period of time some other abnormalities, then you can repeat the test as per the requirement.
Yeah. So I'm so glad because, sometimes we still see that what has been ordered is hemoglobin TCDC. So let me tell you, there are very few labs in India who do it manually. They all use automated cell counters, so whether you ask it for not, all the RBC parameters, the platelet count, they are being generated. How you approach it has been described by Abhay, so you don't worry, you don't need to manage. What will you tell your patient about the next pregnancy? That is what I want to know from the obstetricians.
No. Is there any report of platelet count in between the pregnancies, like when the patient was non-pregnant?
Yeah, we do not know because it was never done.
Because this looks like maybe ITP. It is too early in pregnancy
Yes.
to have
So
low platelet
thanks
count.
for pointing that out. That's why we say, delivery is a celebration, right? The problem is, after that, we need to know, because as you rightly said, and pregnancy is one condition where platelet count can go down due to so many reasons, as was shown, right? So, ideally, after about 4 to 6 weeks, people say that we need to repeat the sequence. That was not done. So, this is a real patient. So, we do not know. Now, suppose you are suspecting ITP, would you call the patient back to you or would you refer it to Abhay sir? See, I'll tell you a fact. Why I asked you. The obstetricians are being held in highest esteem. Yeah? They bring life to earth. So it is always better that you do the follow-up. Because rather than they go to a foreign person. So my sincere request here is that, you just have a look, because there are 2 episodes and no one knows what happened in between. So thank you. I think that was excellent. I go to the second leg. I'll give you a bit more history here. Anemia. Anemia in pregnancy, you can spend 2 days on that. This is Mrs. MG, a 26-year-old lady, married for 5 years. Incidentally, when I got this history, she was residing at Nasik, but her in-laws were in Kolkata anyway, and gynecologists understand this better than us, G2, P2, A0, presenting with complaints of jaundice, weakness, lassitude, palpitation, shortness of breath on exertion, pedal edema for the last 3 months. So looks like symptomatic anemia and something more than that. 28 weeks of a singleton pregnancy. History of a mid-trimester MTP in last pregnancy about 3 years back. History of jaundice during the last pregnancy, and she was HbSAg positive, but the gastroenterologist saw her and said she doesn't need any treatment. History of blood transfusion at that same time, okay? Then irregular follow-up in the liver clinic. So what the gastroenterologist said was 1.5 years back. Maybe was asked for follow-up, but lost to follow-up is one of the greatest gaps we have, and we can use it. No history of menorrhagia, polymenorrhagia, postmortem hemorrhage, post-pregnancy, bleeding PR. So iron deficiency is not likely, persistent fever, weight loss, bone pain, these were not there. No anti-epileptics, tapeworms, no family history suggestive of hemolytic anemias, no history of thrombotic episodes. So, when the patient was examined by the obstetrician, significant pallor, icterus present, palpable splenomegaly 8 centimeter, hepatomegaly 3 centimeter, bilateral pedal edema, no lymphadenopathy, normotensive, regular pulse. Even they looked for sternal tenderness, they couldn't find it, right? Obstetric examination wise, single fetus, longitudinal lie with cephalic presentation. Fundal height and abdominal girth corresponding with period of amenorrhea. So apparently there is no IUGR, right? Systemic examination, ejection systolic murmur at the cardiac base, pansystolic murmur at the apex. This can be due to anemia. Normal jugular venous pulsation, pressure does not appear to be increased, no basal crackles. And before I go to the lab findings, any of the obstetricians on how they would start thinking. Because the lady is with them. Anyone, I think.
It looks like hemolytic anemia only.
Yes.
So it is better to do HB electrophoresis also and do the peripheral smear.
Right. So the first thing I'll show you is the CBC parameters. Hemoglobin 5.6, RBC 1.6 million, TLC 5,200, platelets 1,80,000, MCV 113.7, MCH 34.4, MCHC 30.8, PCV 18.2, RDW 20.2, reticulocyte count 12%. Now, I can't keep the hematologist silent for so long. Sorry, Dr. Indukar and Vishwadip. How would you, Dr. Indukar, interpret this now?
See now you have, thank you organizers for giving us the opportunity. You have given the history of this patient in detail, but just to divert a bit, if you just look at this CBC and not the reticulocyte count, the high MCV and anemia is like B12 folate deficiency, very common in India. So that is one of the commonest thing to look for. Now we know that history, that there was a history of blood transfusion and hemolytic anemia, history retic count is 12%. Now when the reticulocyte count is high, the MCV can go up because the reticulocyte is a big cell, and so that's why there is macrocytosis and you see the polychromasia on the peripheral smear. And apart from that, reticulocyte count, one should look for late normoblast and RBC morphology. Even if there is MCV is high, you still need to look at the target cells, sickle cells, because in any sickling, marrow proliferates, so retic count can go up. So these are the typical findings in RBCs one has to look at.
Right. And so, just a reticulocyte count alone does not give the full information. So, a corrected reticulocyte count, and then if you get polychromasia, you look at RPI, because at one glance 12% would look to be very high, but look at the hemoglobin. So, it's almost 1/3 that of normal. So, automatically corrected reticulocyte count comes as 4%. So, thank you, Dr. Indurkar. I'll give some more findings, but Vishwadip will tell me what he wants to know.
We will like to know the peripheral blood smear, what it shows on the smear, and is there any evidence of a spirit?
Yeah. No. See, if gynecologists are asking this question, we are the happiest people on earth. So, Vishwadip can wait. I'll first answer, ma'am, right? So, very good. Peripheral blood smear kya bol rahe? So, they said there is anisocytosis, there is macrocytosis, there is polychromasia. So, polychromasia means that usually you are seeing red cells and you see those blue dots because there is some RNA, right? Significant anisocytosis, and they have not mentioned anything else on the peripheral blood smear. Now, Vishwadip, anything else would you like to know from the peripheral blood smear before I go to other areas?
This is quite a complex scenario, but like with the limited knowledge we have. So one thing we want to rule out, whenever there is increased reticulocytosis in a patient requiring transfusion, one clinical history is important, that transfusion, does it increment the HB? Then other thing, peripheral blood can show agglutination if there is autoimmune phenomena associated with it. LDH might be high, showing that there is, it suggests that there is some...
LDH was 617, and the person who saw the peripheral blood smear did not comment on agglutination. But so, that's a very good point, because, there are clues on the peripheral blood smear.
So then we can ask for a direct Coombs test, because it can still be there. Although anisocytosis doesn't fit into the lab picture of AHA, but you can still ask for that.
Yeah, so Coombs test by gel method was mentioned as 1+.
So that can be normally present in the population. So 1+ has to be taken in the clinical context. Usually it is normal in the population to have a 1+. Usually clinical significant would be somewhere between 3+ to 4+, and if we see other features of hemolysis in the blood, if it fits clinically, then only we take it as positive. Only DCT positive doesn't mean anything. Then Other thing we can,
And I think she asked for hemoglobin electrophoresis.
HPLC would be.
Yes, that was normal. Okay, so hemoglobin A was around 88%, A2 was 3.3%, hemoglobin F was 0.8%. So then obviously we got stuck. Anything else you want to know, Vishwadeep, or anyone else? Please volunteer.
so this is mostly some unstable hemoglobin which is causing hemolytic anemia.
Right.
So the workup is quite extensive for that. But we have to be sure, like we can ask whether there is a family history, where the patient is actually from, like not from the place they are living in, but where they belong. There are things which are
where
common.
they belong to. And one very important thing is, no one till to date, and let me tell you, no one knows that once you get a blood transfusion, how long your fetal hemoglobin can remain low. So if the patient has not received a transfusion, before transfusing, I know there are emergencies, please collect 2 cc EDTA blood before giving a transfusion. The cheapest way to get to know is if the parents are living, you can look at that. But as he said, if the HPLC comes as normal and Coombs is 1 positive, I think that is the time then we have to start playing. It comes out of that domain because sometimes it's very difficult and unstable hemoglobins and others. And this HbSAg, when it was sent, then the gastroenterologist asked for the HBV DNA and it was also high. So many things start playing that then it becomes difficult for us. So I think we have discussed this. Management is symptomatic, obviously. If it's low, if it affects the fetal outcome, if it affects the maternal outcome, transfusion is the only way then. So I think that is the thing, and you can give folate, but anemia in pregnancy, if it is not iron deficiency, and if HPLC is normal, then it becomes a difficult story.
So I wanted to add one thing.
Yeah, please.
In cases of liver involvement, you can have hemolysis also, like Heme syndrome. So you should also look for not so common things also. When you are not getting the common things, just don't keep like managing without looking also. Keep looking, keep managing, but find new reasons why it should happen. Because she might have Wilson's, which is not yet symptomatically presented. Or maybe CLD, because hepatosplenomegaly is also there. That can be in addition to hemolysis.
Absolutely.
How frequently do we transfuse?
Yeah, so that also does not depend on the hemoglobin level alone. We usually keep it to the obstetricians depending on what kind of symptoms the mother is having. Frequency can be anything, but the problem is, remember that as you frequent say every twice a week or something, the chances of developing allo antibodies are more. So the blood bank should be clearly informed that, this lady might, I can tell you there are beta thalassemia carriers who had a normal hemoglobin. They decompensate during pregnancy. Okay, you manage the pregnancy, they get it, and after the delivery they are back. And no one knows, it's not hemodilution, there's something else going on which we don't understand. So I think here a transfusion medicine specialist role is very important. They should screen for antibodies, and if it is possible, there itself they should know the complete blood group phenotype. So if you know even the Kell, Duffy and others, and you give a phenotype matched blood, your chances of increment and persistence of the hemoglobin level is better.
Because she is at 28 weeks, so we still have to
you have to carry
care her
and
for 6 weeks at least.
You are the captain, remember that. We are the wicket keepers, we are standing there.
Many times non-playing captain.
But you have to do it.
Sir, in this particular patient,
Yes.
can we wait till the full term, or once the fetal maturity is achieved, is there an indication of termination of pregnancy? Second thing is, if as you said, regarding the frequency, her hemolysis is very significant. If you need to transfuse her very frequently, so can that become a ground to induce such patient?
Yeah, so
and does this patient need an indoor admission? Can they manage on the outpatient?
Yeah,
basis?
so now it becomes a high risk pregnancy.
Yes.
the decision would be based on your assessment of the maternal and fetal outcome. So if you think that you're not being able to maintain adequate oxygenation, even after transfusion, because there is splenomegaly, no one knows how much degree of hypersplenism would be there, then that decision actually rests on you. Maybe the neonatal care people can also comment whether you'll go in for early lung maturation and do an early delivery.
We can give steroids?
Yes, you can. We don't have a problem. Because our problem will start once the baby is delivered. Then we need to know what is happening, right?
And in case, sir, if you are not able to pinpoint the cause, there
Yeah.
can be condition something called as a idiopathic hemolytic anemia of a pregnancy.
Yeah.
And in this particular patient, can we give them a steroid trial?
No, that would be difficult to see because she has a history of blood transfusion. You might say that was also during pregnancy, but anything idiopathic is idiotic for the patient, idiotic for us and pathetic for the patient. So we would like to know what is going on. And most of the time they even have antibodies. That's why I told you, you need a good transfusion medicine person who will look for those antibodies. Steroid whitewash without knowing what is happening, will not solve it. That is usually our approach. Thank you. So the third lady, asymptomatic thalassemia screening was done. Madam told they are doing hemoglobin electrophoresis. Occasional history of jaundice was there. No history of aches or pains. Lady is from Maharashtra. This is the HPLC. So I think any of the hematologists can interpret. I have given the diagnosis also. But you can speak something about the HPLC and then I'll go back to our obstetric friends. Sorry, the quantities are not given, but HbS is quite high, right? So A2 is high and fetal is reasonably high. It's around, I think, 4.55%.
Sickle cell.
Yeah.
So basically, it suggests mostly HbS, homozygous disease. A2 can be high when the sickled hemoglobin is glycosylated, it can fall into A2. But yeah, there is a possibility of associated thalassemia with this. But that is dependent, like we should see more on the smear whether there is microcytosis associated with it in this patient, because if microcytosis is not there, there is less likely to be associated thalassemia with this. Only pure sickle homozygous state will be there. I think that is...
But the patient is asymptomatic, so how commonly do you get it? Because this is the sickle cell belt. I would like to know, do you get asymptomatic homozygous sickle detected for the first time in pregnancy?
We get
Usually no. Yeah, so this is not common. Now the approach and management wise is, because the mother, the fetus, the family and the society. So obviously screening and then newborn screening and other issues come up, but I see our time's up. So obviously I should thank my team members. No more academics, only food for the stomach, not for the thought. I just tell you one thing, no more ladies today. We had a good time and I would like to thank them. Thank you.